Listen, folks, we do thank you so much for being right here with us. What's eating you right here on the Real Rhythm of the City? You know, we have a topic for you and your family and friends to really enjoy. We want to get into not only wounds, but also chronic wounds. And what is an infection? You know, I thought I knew what an infection was. I thought I knew all the parameters around the infection. But come to find out, I am glad that we are doing this show because there are some important empirical data and some empirical information that you may need to hear about infection as well as wounds. Not only in foot wound, of course, we're going to talk about the feet in particular because we are here with the Physician of the Year for 2013. And that is the Honorable Dr. Richmond. Now, she is at the Drew Health Center, located on Paul Laurence Dunbar and Dr. Martin Luther King Way, or 3rd Street. And her hours of functionality are from 9 a.m. to 5 a.m., Monday through Friday. Her number is 937-228-3668. That's 937-228-3668. Yes. All right. Doctor, how you doing?
I'm doing wonderful today.
All right. Well, just today, how were you doing yesterday? I want to ask.
Talk about it.
You don't want to talk about it? You know.
Well, I was in the dog pound yesterday in Cleveland, rooting for my team, the Saints. And
yeah.
I'm kind of happy we did lose because I got out safely.
Oh. Well, you barely lost. You know
we barely lost, but. You know, they're a little hostile, so I was happy to...
Not the dog pound.
I was happy to come back to Dayton.
Okay. Listen, let's get in real quick. I found out that there is a term called chronic wound. And it is a wound that doesn't heal anywhere from 4 to 8 weeks.
Yes.
Talk to us about that.
Well, there's acute wounds and then there's chronic wounds. Acute wounds would be less than 4 to 8 weeks. Chronic wounds are 4 to 8 weeks or longer. Generally, when I treat diabetic foot infections, unless I see the patient initially, I generally do get them at a chronic state. They may have tried other treatment modalities. They may have gone other places and their wound will not heal. Actually, wounds are multifactorial as far as how they heal or why they won't heal. So, say the person is a diabetic, but say the person is an uncontrolled diabetic. So if they're uncontrolled, then the cells that can heal that wound don't work. The cells that can fight infection don't work. Say if their blood sugars are high, then overall the person is sick. But then say the diabetic is also a smoker, so they don't have enough blood flow coming in to the wound to heal the wound. So it's a lot of different issues, and then it's all about how compliant is the patient with, how are they doing their dressing changes as instructed, are they staying off their foot as instructed, or you know, are they, like a lot of patients like to keep their wounds uncovered, and that's an open wound, that's a sore on your foot. You know, there's all kinds of things in our environment, all types of bacteria that can land on the wound and infect the wound. Or say you have a person in your house that's a MRSA carrier. You may not have MRSA, but if you have a MRSA carrier breathing on the wound, then they can infect the wound with MRSA. So it's a lot of different issues that come in with just making that wound or getting that wound, getting the person healthy enough so their body can heal that wound.
You know, in the research, I have found 3 key different opportunities that could give you a horrible problem with chronic wound or cause a wound to become chronic. And one, as you said, was blood circulation.
Yes.
And there are several ways you can arrive at blood circulation. Everything from not only smoking, but perhaps maybe wearing clothing tight, having tight things on at the wrong time, crossing your legs. If you cross your legs all the time in that particular area can cause blood flow issues. And so there are several different ways that you can have that lack of blood circulation. And you may talk about more of it because it was just by research. The other one was it keeps coming up, and I noticed last week we were doing the show, we did a little talk about it, but it was interesting. It talked very heavily about non-compliance. balance.
Yes.
And one of the reasons, say for instance, a person is working and
Yes.
they're out to trying to get back to work, they will dress the wound as they see fit to make sure that they keep work opportunities, though it may hurt.
Yes.
But they're trying to do certain things. And here comes the bathroom surgery, here comes the bedroom surgery, and all these other things other than going to the doctor and getting proper treatment or wound dressing care.
Yes.
I looked at that intently, and I understand that those who may want to heal this aggressively may not do it on a time frame because they have not had proper dressing or trained up on the issue. Talk to us about that specifically.
Well, the main thing, especially in diabetics who are quote unquote neuropathic, which means they feel nothing. So, say this person is a neuropathic construction worker.
Wow.
They're going to go to work, they're going to dress their wound, they don't feel pain. So they're going to continue to work.
Stand on it, run on it, lift on it.
So, in their mind, they're not doing harm to the foot because they don't feel pain. So that's another issue that we deal with. There's different modalities we can use. You can put a patient in what's called a total contact cast, which is technically a cast, but it's designed to offload the bottom of the foot if the ulcer is on the bottom of the foot, which most of the time diabetic foot ulcers are on the plantar aspect of the foot. There's things like cam walkers. You can put them in and offload the foot. You can put them in other modalities, or you can just try and tell the patient to stay off the foot as much as possible. But I understand when people have to work to survive, but as a physician, a patient, myself, it's you have to really impart to the patient, you have to stay off this foot, because if it gets infected, then you possibly could lose your foot, and then you won't be able to work. Well, not until you get your new prosthetic limb.
Which means it has to be cut off in order to get one.
And then you have to go through your rehab, get your new leg, learn how to walk with that new leg, and then go back to work, which should be a year later.
Yeah.
But, a lot of people, especially when they don't feel the pain of the ulcer, it's just kind of, it's a negligent little thing on the foot because they don't feel it. So they kind of look at it like, oh, it's not that bad. I don't feel any pain. I have a hole in my foot, but I don't feel anything. So they kind of just deny it's there or kind of ignore it.
Yeah.
But as far as me, I have to try to impart to the patient, you have to stay off this foot. You have to take care of your foot. Do not soak your foot. I tell them you're giving the bacteria a spa treatment.
Yeah.
That's all you're doing.
To go into your bloodstream.
Well, no, you're giving the bacteria a spa treatment because the bacteria like warm, moist places.
Mm-hmm.
So you soaking them in hot water.
Mm.
The bacteria is having a good time in that ulcer. They're growing, they're multiplying. It's not killing anything. It's giving them an environment where they'll grow even more.
Spawning.
So you want to keep the wound dry, you want to keep the wound covered, you want to do proper wound care. That's why most of my patients who can qualify through their insurance, I always send home health to their house.
Gotcha.
So the wound care nurse is monitoring the wound between the weekly visits that I see them. And then patients will say, well, why do you need to see me weekly? Because a diabetic foot can go bad quick. It can go bad overnight. You can go from a healthy foot to gangrene the next day.
Ouch.
You can be healthy the next day could be septic. And I see it all the time. And that's why I want to see you weekly. So as soon as I see any signs of infection or complications, I can get you on antibiotics quick, or I can send you to the hospital where you can get IV antibiotics.
I did not make this difference in my research. I couldn't find that. It could be because, I'm a little slow. Okay, I admit that.
No, you're not slow.
But I'm trying to figure out, when does a wound turn into an ulcer? Is there a transformation? How does that happen?
Well, there's staging of wounds. So they go from stage 1 to about stage 4. Stage 1 is a pressure wound. It is not open yet.
I got you.
So and most of the time when you see what's called pressure sores, you'll see them like in the nursing home or someone's bed bound.
Right.
But stage 1 means if you press on it, the redness will go away and it'll come back. You'll start to see bruising. but the skin is not broken yet.
Does that mean there's bleeding on the inside?
Yeah, it's bleeding into the skin, but then that's a stage 1 pressure ulcer. So especially hospitals, nursing homes, that's why they're always turning their patients, looking at the patients, they're especially looking at their buttocks, their elbows, their heels, because those are high pressure points. And now Medicare doesn't reimburse if you develop an ulcer while you're in the hospital or nursing home, so they have to be overly aggressive to prevent these things from happening. But in a foot ulcer, it presents the same way. So if I see a callus with blood in the callus, I know that's a pressure sore. It may not be open, but I'll debride it down to see if there's an opening in there. But generally, if I see a diabetic that's neuropathic, they have loss of feeling, and they have a callus with blood in the callus, it's either an ulcer or it could be an ulcer because it's a high pressure point.
So that's why you need to observe on a constant basis to see what stage that is being developed or not being developed.
Well, they need to see me because really a person, unless they're a wound care nurse, doctor, or specialist, they can't stage their ulcer. But like I always say, any kind of marks, changes in color, if
can
it
develop
wasn't,
into ulcer.
well, no, if it wasn't there before, it needs to be checked out, especially if you're a diabetic, and especially if you're on blood thinners too, because you can bruise easier if you're on blood thinner. Or if you have just PVD, if you've been told I have PVD or PAD, peripheral arterial disease, you're higher risk for problems. Then if you're a smoker, you're higher risk for problems. So I always say, if your foot looks different than it looked yesterday.
Yeah.
If one leg is swollen and it wasn't swollen yesterday, if one leg is red, one leg is hot, if you have dark spots on your feet that weren't there the day before.
Or numbness?
Numbness as well, because numbness can go to complete neuropathy, which is loss of feeling. And there's medications for the numbness, tingling, burning in your feet, so you don't have to suffer through that. But you also need to be educated, because if you're having numbness, your feet are now high risk, because they're starting to lose what's called your protective sensation. What protects you if you step on a nail attack from reflexively pulling back.
Mm-hmm.
So I always say, if it wasn't there before and it's something new, it needs to be evaluated.
Very interesting. Okay, I was soaking all that in and everything, because it also opened up several different questions. But before I get into some of those questions, we're going to go ahead and take a break. All right, once again, we do thank you so much for being here with us. What's Eating You on the Real Rhythm of the City. During the break, we were talking about a person that had come in your population a little while ago, and you used the word septic, meaning that the bacteria had entered into the bloodstream.
Yes.
And talk to us about that particular complication if we are unfortunate to get to that point.
When you are what's called septic, you'll present with nausea, vomiting, fever, diarrhea, chills. You're systemically ill. The bacteria has gone from the wound, is now in your bloodstream.
Kind of like food poisoning? Kind of sounds like
probably worse.
Really?
Yes. Because if you're septic, it's a medical emergency. You need to be in the hospital. You need to be on IV therapy. You need a team of people taking care of you. You need the hospitals taking care of your primary care, your diabetes, your hypertension. You need infectious disease, making sure you're on the proper antibiotics. You're most likely going to need a surgeon because something is about to be amputated.
Ouch.
So you need a surgeon, you need a podiatrist or orthopedic surgeon on call. You most likely need a vascular specialist as well. Because if you're that sick, generally they have a multitude of other complications with it. So by the time a person comes to me with a diabetic foot infection, to the point that the toe, in this case, the patient's toe, she had gas gangrene in the toe.
What's that mean?
So she had gangrene. It was dry, it was wet, which means the actual cells, the bacteria, actually give off gas, and that's an emergent situation. They're going to the OR as soon as they can get them to the OR.
Now let me ask a question. Now when you say gas, does that mean
It's physically gas and tissue. The bacteria is producing gas, and it's a bad situation. You need to get that tissue off the body, because if that infection hits your bloodstream, she was septic, but she could get even more sicker.
Though the pain sensations may have been gone.
Yes, she did not feel pain.
Does the gas gangrene give off an odor or a fragrance?
Gives off an odor. In her case, you really didn't smell it, but just from being around a lot of diabetic foot infections, I just knew her foot was very badly affected. Plus, she had systemic symptoms. She was lethargic, which means she was very weak. She was just kind of very sluggish. She was having nausea. She was having chills. She was having fever. Her blood sugar was elevated. She was systemically sick as well as her foot. Her foot was making her sick. So in those situations, I asked the patient, which hospital do you want to go to? Tell the patient they need to make arrangements. They need to go straight to the ER. I contact the ER and let them know they're coming.
Do you sometimes, do you have them transported?
Sometimes. It depends. If the patient cannot drive or does not have someone that can drive them, I have them transported. Actually asked her, did she want to be transported? She said she could get there. But she did go. I checked later. And actually I received the op report. They did amputate the toe that was infected. And this person was a repeat offender. She had a toe amputated last Thanksgiving. So once you start this process, you're high risk for more. And I'm kind of confused on why this particular patient waited so long, because she knew the signs of infection. She knew what it meant, how it felt to be sick. Yeah. But a lot of my patients just have fear. It's just that fear. But the fear is what causes them to have even more of a complication. Because when she first saw the ulcer and came in, she probably would have never made it to this step, because she would have been on antibiotics. Right. You know, I would have cultured the wound, so I would have put her on appropriate antibiotics that could have killed that infection. So she wouldn't have come to me at the point where she was septic and had gangrene in her toe.
You know, you were talking about less than a year for another amputation, and one of the things, as I said at the top of the show, that I found out that was very interesting, a high rate of non-compliance.
Yes.
And it didn't talk about fear, but fear could produce non-compliance. So I guess that's why that wasn't in there. And again, I maybe it was in there and I overlooked it. So I want to leave that as an opening opportunity. But, you know, under the umbrella of non-compliance, how many, let's say for instance, your guesstimation, out of 10 patients that you may see that could be avoidable before they become, gas gangrene or septic or something of that nature, how many are in non-compliance out of 10?
All of them.
100%, 10 out of 10.
I talk about the patients who do this, and this particular patient does the same thing. She goes off the grid, and she doesn't come back until she has an infection. On average, that's why the government, the Medicare, Medicaid, insurance companies like for podiatrists to see their diabetic high-risk patients regularly. I see most of my diabetic patients every 63 days, just for routine foot care. And people say, well, you don't need to do that. I do. I'm trimming your nails, I'm looking at your calluses, I'm looking at your skin, but I'm checking your entire foot out. I'm looking for things that can go bad in the future. And then I'm educating my patients. The patients that follow what I tell them don't get amputations. Because I have patients coming all the time, well, doc, I saw this spot, I just wanted you to look at it. And I'm like, you did good, you get your gold star. You know, I have to really pamper the patient, make them feel good for what they did. They're taking an active role in their health care. And most of the time it's not anything. Sometimes it is. Sometimes it is a cut or a scratch. But then that's when I order them antibacterial ointment. I order them dressing supplies. I give them written instructions how to take care of this wound. They're instructed on signs, symptoms of infection, redness, pus, drainage, pain. They're instructed to come see me or go to the ER if they can't get to me. So when the patient is educated, when the patient is knowledgeable, and when the patient is compliant, then they're less likely to have the amputation. It's the patients that I see when it's too late.
Let's get into what caused them to get too late. what are some of the, I guess, itemized conditions of noncompliance? In other words, could it be diet? Could it be not
Yes.
listening to the wound dressing instructions?
Well,
or
they
all
don't
of the above?
even they don't even get to that point. They never come.
Ouch.
They don't come until the foot is gangrenous. There's septic. There's pus coming out of the foot stinks, the foot is nasty. They've been at home washing this foot for the last month.
Wow.
They've been at home soaking it, bleach, Listerine, what is it, apple cider vinegar, what is that stuff? The bubbles, hydrogen peroxide, does absolutely nothing.
Really?
They're using some ointment from 2010 they found in their medicine cabinet. They're calling they're calling their family members who don't work in the medical field, asking them for treatment options. They might find some old antibiotics from 2009. They might take a couple of those.
That may be prescribed for someone
They
else.
might read something on the internet and try that.
Wow.
So it's because they're out of fear of having an amputation or knowing someone who has an amputation, they will not come to the doctor. They don't show up until they're sick. Like I said, they're septic. They're so sick, they know they have to see someone.
Could the conditions somewhat, I guess, flank over or, I don't know, shield their logic? Because it appears to me that if you're fear of some type of amputation, you would go see the doctor.
No. I mean, the illness doesn't change. I mean, once you hit the point you're having mental status changes where you're thinking differently, that is a medical emergency. It's now affecting your brain. But most of the time, they're very aware of what's going on. I mean, I had a patient that came in, he had a 1 week follow-up. He came in 3 weeks later, he had dry gangrene of the toe. And I asked the patient, you had a 1 week follow-up. How come it's been 3 weeks since I saw you last? Because all my wound care patients, I see them weekly till they heal.
Yeah.
He really didn't have a good reason. He just didn't come back. But he came back when his foot started turning black.
Wow.
But by that point, it was too late.
Ouch.
So,
I'll tell you, that's interesting.
Yeah.
You know, I'm just boggled at, I guess it takes, now, you know, when we talk about owning your health, I remember someone was talking about that term and didn't fully understand exactly what that whole term is. Owning your health means to think logically and critically, have critical dissolving thinking skills to make sure that you are being proactive as relates to getting some of these things taken care of in a decent order. That's very interesting. So you're getting people who may have their follow-up, missed the follow-up. They get in now into what you said this subject had a dry gangrene. Real quickly, what is the difference between wet or gas and dry gangrene?
Dry gangrene, the toe is dry. Mm-hmm. So it's more stable than wet gangrene. Still with dry gangrene, you're going to need an amputation. You have more time. Wet gangrene, that amputation is either that night or the next day.
Interesting. Okay, folks, there you have it. We're going to, we have actually talked about some of the infections and the different kinds of infections and how easy it is to get an infection. Give the doctor a call at 937-228-3668 to ask any questions that you may have off air or make a consultation or make an appointment. I'm telling you, it would definitely be worth your while. Also, when you
back to What's Eating You.
All right, we do thank you so much for staying right here with us. We're going to change gears just a little bit because we have a lot of information we're going to impart today. And we want to talk about cellulitis.
Yes.
Talk to us about that.
Cellulitis is a soft tissue infection. So generally people who have cellulitis will present with one leg that's red, hot, and swollen. Patients who have what's called venous stasis or venous insufficiency, those are the people with the big swollen legs. They usually also get ulcers on the inside of their leg. They often present with cellulitis because the chronic nature of the disease makes their skin prone to skin breaks. And then even a tiny little break can get infected. And then lots of times they'll present with cellulitis where the whole leg is red, hot, and swollen. Generally, they'll need some form of antibiotics, either oral antibiotics by mouth or IV antibiotics. And also, when you have the diabetic foot infections, they can present with cellulitis, and that's even more scarier for us because if you see what's called streaking, which means it's going through the lymphatic channels, you'll see redness going up the leg. That's even worse. So they immediately need to be in the hospital and put on IV antibiotics.
Let me ask a question. Is it possible that you can get gas gangrene in the inside of the leg upward? I think I heard you mention that. But my concern is, how do you get ulcer inside the leg?
You don't necessarily get ulcers inside the leg because ulcers are a break in the skin.
So
the
that
actual outside skin. But what happens is the ulcer can get deeper and deeper and deeper. So it can go from general skin to it can go to muscle. It can go to bone. So when it goes to the level of bone, it's deep enough, it penetrates bone. That's when you can get osteomyelitis, which is infection of bone. Now, depending on who you may deal with, they may put you on IV antibiotics for 6 weeks or longer, or they may amputate or debride out the infected bone, depending on where the actual osteo is, in the foot or anywhere else in the body.
How often does that bone turn into a point where it is deteriorating?
I actually had a patient about a week ago. He had osteo of the distal toe. He was a type 1 diabetic. He had an ingrown toenail. He was picking at it. He was doing his bathroom surgery. And he probed deep enough in his toe that the bone in the tip of the toe was infected.
Because he didn't feel it?
Yes, he was completely neuropathic. He was a type 1
Ouch.
diabetic. So he was in his 30s. So he had been a diabetic since he was a small child. So type 1s, they usually have more of an aggressive complication rate because their diabetes is harder to control most of the time than type 2s because of the way that the disease works on the body. In type 1s, they don't make insulin at all. Type 2s make some insulin. We just don't make enough.
Very interesting. Boy, I tell you, it's really got my mind going. I mean, so in other words, you can have the sensation totally gone, that you can have a sharp instrument. I'm gathering he was using a sharp instrument that probed all the way down to the bone, and he didn't feel it?
No.
Was there any, I guess, anything he noticed as it relates to pain with the infection?
No.
So
no pain.
So he just saw it?
He saw the pus. He saw the drainage. He saw the swelling. But he didn't feel any pain.
And he eventually had to get that toe amputated?
Actually, I saw him on follow-up. I sent him to one of my vascular specialists. He was admitted to the hospital. After he was given IV antibiotics, the toe did look significantly better. And she decided at this time they're just going to try a course of IV antibiotics for about 6 weeks and see if the osteomyelitis resolves. So she decided not to amputate his toe, and we're going to work together and just monitor the toe, monitor the wound, so hopefully he doesn't get any further infections until his toe heals.
Interesting, you just brought up further infections. Is there such thing as this condition being chronic?
Yes. Well, lots of times patients become carriers. So they become a MRSA carrier or a VRE carrier. So it's
as a direct result of the bone?
Well, from being exposed, you may be exposed in a hospital setting. Most patients that are in the hospital a lot tend to catch MRSA. It's just being in that environment. I mean, it's a lot of sick people around, so you tend to become infected chronically with MRSA. So that's always important. I always tell my patients, especially if I'm doing any kind of procedure or if they're coming in with an infection, that's my first question. Have you ever been cultured with MRSA? And that changes the entire treatment plan because I have to go to the most aggressive antibiotics. I need to be culturing your wound. I need to know exactly what will kill the bacteria that lives in your wound. I mean, but based on the fact that you have MRSA, that'll move me to antibiotics that will kill it most of the time. But if you're systemically sick, with the nausea, vomiting, fever, the diarrhea, the chills, you're going to the hospital because now it's in your bloodstream. You need
Wow.
an entire team to make sure you don't become deceased or anything else from this infection besides losing your leg.
So, in other words, it all starts from that extra piece of pie or being non-compliant as it relates to that diet.
Yes.
To get you aggressively into a point where you are getting some form of neuropathy. Your sugar spikes have
Yes.
gone up to the point where neuropathy is setting in and you don't feel any pain sensation or anything in your reflex sensation in your feet.
Yes.
And then you may step on something, cause a wound that can turn into an ulcer, and this ulcer can cause you to get amputated, bloodstream, septic, all of the above.
Yes.
And you can actually be fatal all because of that extra piece of pie. Or I'm
Yes.
just, I mean,
Yes.
you know, you got to look at the beginning, because as we talk about the whole family of medical issues that this can open up,
Yes.
that's seriously, that is a serious situation. That'll make you put down that potato chip. That'll make you, you know, leave that bowl of ice cream alone, or
That
whatever,
beer.
or that beer, or that alcohol. Put down that cigarette and everything. So,
Yes.
and in fact, if you have an issue with all those things, guess where you're headed? Sooner or later.
It's
You
a
know.
possibility. Or you may not have an amputation. You may just have a stroke or a heart attack.
Wow, Doc.
Or you may go into renal failure. You may go blind.
Really?
And many
Kidneys and
times-
eyes.
Yes, because diabetes affects everything. Just for me, I'm a foot and ankle specialist, so I concentrate on the foot and ankle.
Gotcha.
But diabetes affects the whole human body. It's like a devastating cancer in the body. And the higher your blood sugars are over time, the worse it, the more problems it can cause.
So that sweet tooth can be
It
deadly.
can kill you. Yes,
Yeah.
it will kill you.
Wow.
Yes.
So, folks, anything that you have in your diet or anything that you have in your, I guess, mindset that will make you non-compliant.
Yes.
You know, even if you already have a wound issue, if you are non-compliant, you know, let's take a look at this. If before you get to that, I always like to be before the fact. You know, the
Yes.
best way to solve a problem is to prevent it. You know, come from that perspective. And so if you get in a position where you are at a function or maybe have that desire to eat that extra thing that you know is not supposed to be in your diet, guess what? You need to grip up. You need to be mindful that this can kill you. Not something that may kill someone else, but can kill you.
Yes.
Because one of the things that we were talking about in the compliance issue is folks always think, not me.
Yes.
You know, this is not true with me, or, you know, what have you. Then the next line they would say is, you know, I didn't see that coming. You know, I didn't know this would do it when you knew it would. You know, and then what do we, and I want to get personal for a second before we go to break. What do we always say when we're in that I see you or in that position? Lord, if you help me out of this one.
Yes.
And so I want to bring those things to a mindset before you get to that point. Make sure all your disciplines are in order. Make sure you are living appropriately, or maybe, you know, you are doing the best stern work you can to be compliant in all the rules of the particular thing that you have, no matter what disease you have. Don't forget, folks, diabetic issues are chronic issues. They are progressive issues. They will continue to pop up. They're not going to go away. You can monitor it. You can, you know, you can keep it at a very low level, but 9 chances out of 10, you're not going to eradicate it, at least not now. There are some plans on the books. I was told that there are several plans on the book to take diabetes out. But
There's treatments. There's
Yeah.
cures.
There are
They
cures?
have issues.
we'll talk to us very quickly about that.
Well, I mean, you can get a pancreatic transplant. They now do kidney and pancreas transplants.
to stop the diabetic conditions?
Well, generally what happens is the person's been diabetic so long, they're in renal failure.
Uh-huh.
So while they're into giving you a new kidney, they'll give you a new pancreas.
But you have to be on the list for
You
that.
have to be on the list, but you're on immunosuppressants for the rest of your life.
Immunosuppressants, what is that?
Those are drugs that make your immune system not attack that new organ. So you're taking maybe were taking pre-organ transplants, maybe 5 drugs, but after you may be taking 10 to 20 to keep you from rejecting that new organ. And the new pancreas will not reverse the complications of diabetes you had before. So I had a patient, he was legally blind from his diabetes. He now has a new pancreas, he now has a new kidney, but he still can't see.
Right.
Because the damage was done by the diabetes. And he'll have to be on medications for the rest of his life. And then you have like the gastric bypass. That cures a lot of people of their diabetes, but it does not reverse the complications they had before. I had a patient who has as well. He still has neuropathy. He still has an ulcer on his foot.
Wow.
Because he still can't feel. Because the neuropathy did not reverse from him not being a diabetic anymore. And he's having a lot of complications from the surgery as well. So, you know, the easiest thing, yet the hardest thing, is just to control your diet, just to be compliant, just to do what your primary care physician tells you to do, just to take your medications, just to come see your podiatrist, just to go see your eye doctor, just to go see your dentist, and just follow all the different things, which I know is hard to do, but it's easier than going through these extremes to try and cure your diabetes. The easiest way is just to lose weight if you are a type 2 diabetic.
So, in other words, you're not going to be able to eat those foods. You're not going to be able to live that sweet lifestyle. Either way it goes, you're going to be in a drastic condition where you have to knock it off.
Yes. I mean, everything is, you can have some things. You still can have a piece of cake, but you can't have
the whole cake.
The whole cake. Or you can have a sliver of cake. But then you have to realize you can't have any other carbohydrate with that cake.
Yeah.
So you can't have that cake plus potatoes plus rice plus some macaroni and cheese and a regular drink.
And a scoop of ice cream.
Yes, you can't do that.
Or a slice of pizza with that.
Oh yes, that's another carb. So if you wanted that piece of cake, then the only thing on your plate should be protein or vegetables. So it wouldn't raise your sugar as much. And then you might want to go take a walk, a light stroll after you eat that cake, so it'll make your blood sugar drop, so you won't spike after eating the cake.
That's why it's always good to walk after you finish eating, regardless of even if you are watching it, even though you are made.
Well, exercise over time will keep your blood sugars levels low, because muscle when you exercise, your muscle does not need insulin, so it just brings the sugar into the muscles and it'll drop your blood sugar.
Interesting. Okay. Well, folks, there you have it. You're going to have to stop it sooner or later, one way or the other. How do you figure? You know, it's interesting that though you may get a pancreas transplant or a kidney transplant, you still can't go eat what you want to eat, because you talked about some of the symptoms or things that are in other parts of the body doesn't attack the new organ.
Well, you can eat what you want. You are no longer diabetic, but any complications, they don't reverse.
They don't reverse.
No.
So eating what you want doesn't mean that you can go ahead and have that whole cake.
Well, you have a new pancreas. You can destroy that one too. You can wear that one out too.
I guess that's one way of putting it. Okay. Listen, folks. Woo! I tell you, this has been a tremendous eye-opening show. Thank you so much for... All right, I wanted to speak to something. I just want to open it out here. I was talking to another minister, and he and I both made the same observations. Sometimes we eulogize different people, and you know what happens. We go back to where they're having a repast, and where they're having a repast, they're serving the same foods that just, you know, just killed Uncle Johnny or what have you. And so we talked about how important it is to also discipline others, because some of our children or grandchildren love to emulate those things that we see. Hold on for just a minute. We have a caller. Hello, you're live with What's Eating You. Hello, you're live with What's Eating You.
Yes, how you doing today, sir?
All right, how are you doing today?
Fine. I was calling because I don't know if many people may know this. I was wondering if your host, I'm quite sure she doesn't know about hot therapy.
Yes.
Yes, my mom, she had her toast and she had to have hot therapy to get the wound closed. And someone said she had got that earlier, maybe she didn't have to get her toe amputated at all. So I was wondering your thoughts on hyperbaric therapy. And I'll get off of it.
Well, hyperbarics is basically where you are put into a device like when we remember Michael Jackson, he was on the cover, he was in this tubular device, he was inhaling pure oxygen.
Okay.
It's also used to treat the bends from diabetes and people exposed to carbon monoxide. But the premise for wound care is you put a person in a chamber and they inhale pure oxygen for about an hour or longer. And the premise is by them inhaling pure oxygen, the red blood cells will bring that pure oxygen eventually to the foot. And eventually it will help the wound to heal. The caveat to that is the person has to have enough blood flow for that oxygen to get to their foot.
I see. So in other words, you still have to work with some type of working order.
Yes, they have to have a good enough vascular tree for the blood flow from those red, as the person inhales the oxygen, for that blood to eventually make it to the foot. Because the more oxygen that gets there, the easier and the faster the wound will heal. Now in her case, I really couldn't answer that question because I would need to know her vascular status. I would need to know, the progression of the wound. I do send some patients for hyperbaric therapy, but the sad part in most cases is in patients who do get diabetic wounds, generally they have horrible blood flow.
Okay.
Because they've had diabetes so long that the diabetes has attacked their vascular system. So in those patients, they would need to be what's called revascularized by a vascular surgeon, where they either open up blood vessels, they can bring in new vessels, reroute everything so they can get enough blood flow to the foot to heal. And then of course, if they're also smokers, then that's a 1-2 punch on the vascular tree. So they have the diabetes attacking their blood vessels, and then they have the smoking attacking the blood vessels. Some people really like hyperbarics. I try it when the insurance companies will pay for it, and then also if the patient is not claustrophobic.
Because as you said, there's a chamber.
You're in a chamber for about an hour.
Okay. Kind of like the MRI.
Well, yeah, but you're enclosed. The
All the
MRI,
way.
you're hanging out.
Yeah.
You're in an enclosed chamber.
Yeah.
So, and then if the patient, if they're morbidly obese, they may not be able to fit in the chamber as well. So it's a lot of different factors. It is a great asset, a great modality if the person has enough blood flow so it will help the patient. But it's also on, like you said, on the patient compliance.
Yeah.
Can they deal with being in that chamber for an hour or longer at a time? And they usually dive about 15, 20 times.
We mean dive.
That's when they put them in the chamber and they drop. I can't remember if they drop or increase the pressure, but it takes them to the level where they're inhaling pure oxygen, and they call it a dive.
Really?
And we call it a dive.
Really?
So they're in a chamber where they're inhaling 100% oxygen for about an hour.
That's
at a time.
interesting. That's interesting. Wow. And so, the best way, again, to solve a problem is make sure you don't get to that point. Is that correct?
Yes.
Okay, we have another caller. Hello, you're live with What's Eating You?
Yes, I apologize for calling back. I wanted to comment on my mom was exactly right. She was in there for an hour, and before that, they tried to get a stick in her vein, and they tried 3 times and couldn't do it. That's why they recommended
Uh-huh.
And she was in there from November 18th to February.
Oh, wow.
And it was long. It was a bit longer because, like you said, that blood flow.
Yes.
And my question was, after the wound has been healed, is there like a yearly, does she have to go back to get exams or?
Is she diabetic?
Yeah.
She should be seeing a podiatrist regularly. Someone like myself, just to monitor her foot. Because once you have an ulcer, you're always high risk to get another one. And generally the skin takes about a year to go back to the original tensile strength before the ulcer. So that area is always high risk for reopening.
Okay. She told me the other day she told there was like a little bump on there. And
Yeah.
I don't know if it was something that need to be having attention to.
Yes. Anything new, especially in a person who's already had an ulcer, their foot is high risk, even higher risk than the average diabetic. And then she has a blood flow issue. You said she was unable to get stents to open up her vessel. So her foot's high risk due to the diabetes and her lack of blood flow. So yeah, she does need to be seen by someone. My number down in my office is 937-228-3668 if you wanted to bring her in and let me evaluate her foot.
228
3668.
3668.
Yes.
Thank you very much. Appreciate it.
Thanks a lot for your call. Appreciate it. You know, that is probably one of the key things, finding out the information. You know better, you do better.
Yes.
I mean, you know, and so when you, let me go back to what I was talking about as relates to some of the children, because we always emulate what we revere.
Yes.
And, you know, sometimes we see some people doing a lot of different things. We always notice that children or those who may revere you pick up some of your habits that you may not realize that they're picking up. You know, and so sometimes, you know, we're often, you know, either taught to look at what does the parent look like, what does the child look like,
Yes.
how's the child going to be if this process continues. And so one of the things that you can do as parents and grandparents, as aunts and uncles and what have you, we need to teach proper eating habits. And of course, some of the problems that we run into is teaching that adult how to eat properly first. You have any classes or you know of any classes about that?
There's actually
Nutritionists.
two classes at Drew Health Center. They have two diabetes classes. If you call or look up the main number for Drew Health Center, you can get in contact with those, or you can just ask your primary care physician who could refer you, if not to Drew. But there's several classes all over the city. Some are free, some are paid by insurance, that teach you proper diet habits. But you know, there's so many studies now that show an obese child will become an obese adult.
Yeah.
And now there's also
Yeah.
the increase of type 2 diabetes in high school kids.
Yeah.
They're having hypertension in high school. And if you think about it, if your child is diagnosed with diabetes in high school,
That's an issue.
by the time they're 40, 50 years old or less, they're going to have some serious complications.
Yeah. You know, there was a report, a research that said, you know, almost 15 years ago, there were no cases of adolescent diabetic or there's another one with the clogged arteries.
PAD,
Yeah,
peripheral
PAD,
arterial
right.
disease.
We didn't have those kinds of situations, or at least statistics or numbers wasn't available to them. But now as hospitals continue to get those kinds of conditions, that doctors begin to diagnose, pardon me, some of our young people with these types of conditions, numbers are being kept. And so there is an alarming rate up into the thousands where some of our young people are getting chronic diseases and high cholesterol and
Arterial disease.
there you go. They getting that. So we want to try to impress on all of our parents the importance of educating some of our young people. Don't forget to give the doctor a call for any and all questions or concerns or consultation at 937-228-3668. That's 937-228-3668. Her hours of functionality are Monday through Friday from 9 a.m. until 5 p.m. She's located in the Charles Drew Health Center. Where is the Charles Drew Health Center? It is located on the corner of Paul Lawrence Dunbar and Dr. Martin Luther King Way or 3rd Street. Listen, folks, this has been a very eye-opening show. Thank you for the information. Thank you for the scare.
You're welcome.
All of us are going to eat better now. You know, we're going to be before the fact, not after the fact. We don't want to get into this septic issue and everything. We don't want to learn too much more about that because we're not going to get to that point. But it is still good to know. Listen, folks, thank you so much for listening.